All right, I'm Andrea Wojtowicz, and I'm a psychologist at Nationwide Children's Hospital in Columbus, Ohio, in the United States.
And I'm Natalie Jacobowski, and I am a child psychiatrist and pediatric palliative care physician at Nationwide Children's Hospital in Columbus, Ohio, in the United States as well.
So we're going to spend a little bit of time kind of in a 10,000-foot view talking about anxiety and PTSD. Our goal is really to discuss anxiety and post-traumatic stress symptoms and how they may look in children of different ages, as well as how they may present in parents. We'll also discuss when symptoms may benefit from intervention.
I got excited.
Thank you, Natalie. The pediatric psychosocial preventative health model provides a framework through which we integrate assessment based on social ecology, understanding post-traumatic stress and resilience, and then the factors that really influence adaptation over time. The level of risk suggests the types and intensity of resources or intervention that's required to really support our patients and families. We are using this as part of kind of our discussion to really help differentiate symptoms and points of intervention. As part of psychosocial standards of care, we are assessing for anxiety and distress really on an ongoing basis, recognizing that you and your child are experiencing events and stressors that do put you at an increased risk. So if we look really at the bottom here of this pyramid, the universal group is really kind of describing or really saying like everyone experiences some level of distress, but there is resilience. Next slide, Natalie. So when we think about universal symptoms or symptoms really commonly seen within this population of children, if we focus first on our early childhood or our toddlers, younger children, some symptoms we commonly seen that are pretty universal is some tearful, kiddos crying, the occasional tantrum, which we expect, right, developmentally within this developmental period. Clingy to caregivers, really, seeking out support and comfort from parents or caregivers. If we think about our school-aged kiddos, again, we expect some tears, we expect crying, avoidance of a task. I think about this really here is sometimes stalling, right? All right, can I have 5 more fruit snacks before I get my central line accessed or before I have to take my medicine? We start to see more expression of worries or concerns. So, you might hear your kiddo saying, I'm really scared to do this, or I don't want to do this. And then difficulty sleeping, worrying, or irritability days before, coming to the clinic or the hospital. Again, really just kind of watching that anxiety build before the events that may happen. Next slide. If we look at the top 2 tiers here in this psychosocial preventative health model, we're now focused on more of the elevated stress or the severe escalating distress. This is when intervention is beneficial. So as parents, I think the take home here is really when you notice your child is not acting like your child, that is really when these top 2 tiers or when symptoms within these top 2 tiers is kind of the point to think of, when things just don't seem like your kiddo's baseline. Next slide. So if we look at some symptoms or some examples of symptoms, so again, within our early childhood kiddos, again, changes to baseline behavior, excessive clinginess, excessive tantrums, not wanting to play, not wanting to engage in really desired activities, not really redirectable back to a preferred activity, difficulty with separation. Something I see commonly in an example would be, when you're at home in a safe space and your kiddo won't let you walk out of the kitchen, or they really won't let you leave kind of their sight. For our school-aged kiddos, again, changes to baseline behavior is another, big marker for us to really think about. Avoidance is a big one too. I think about this as difficulty getting in and out of the car, won't participate, in cares, kind of guarding our bodies, for not allowing our medical providers to access the central line. Difficulties with sleep is another, I think, important symptom to point out. Physical symptoms is another thing we start to see within these school-aged kiddos. So stomach aches, headaches, anticipatory nausea. I think anticipatory nausea is a very common symptom. Examples may be feeling nauseous when entering the hospital, or even at the smell of the clinic, or if the hospital has a distinct smell. Often here in Columbus, we hear about how it smells like alcohol or very clean settings, and often that can trigger some anticipatory nausea. Or not, your kiddo feels nauseous at the sight of a medication or at the sight of their chemo in the infusion bags. Of note, I really, a chronic increase in irritability within kiddos really may be due to anxiety and sometimes not necessarily, other factors. So I just want to point that out, in that it's important to kind of consider and watch for your kiddos. Of note, this is by no means an extensive list of symptoms, as some symptoms can be present, but not really fully a diagnosable disorder. So again, to highlight, your role as a parent or caregiver is really to identify the change that you see in your child, and that's when we'd want you to seek out support. And we know these kiddos and you as caregivers and parents go through a lot, but you know your kiddo best, and that's it's important to point out when you're like, no, this is just not my kiddo. Dr. Jacobowski, on to you.
Thank you, Dr. Wojtowicz. And as we take that further, as Andrea was saying, we really, as we talk about this with you, is it can be really overwhelming as a parent to try to sort through so many things during treatment, to say the least. But also trying to say, well, what type of diagnosis, or what do I need to do? And so we intentionally are taking it at this 10,000 foot view to talk about, where is this level of function, and when do I need to ask for more help to figure out what is happening with my child, and what resources do I use? So we're coming back to this same model we started with. And at this universal level, the things we think about are that, as Andrea said, we have distress. You can't go through treatment as a child or parent without some symptoms, and we expect that. And in that way, we look to say, if your child is otherwise functioning pretty well at home, at school, with friends, in other domains, and they play and they're able to participate in their necessary medical care, but have moments of distress, they likely fall at this universal level. And we have a lot of supports often built in a lot of places, and different for different programs. Here in the United States, that looks like child life support, therapeutic recreation, chaplaincy, routine psychology or therapy support, and overall psychosocial support from the interdisciplinary team. And then we kind of continue up to look at, what if your child is having a little more trouble? And one of the things that I think is really important in this model, and why I like using this model to discuss, is that you can bump up to one phase and then also bounce back down. You actually don't live in one phase or the other and then stay there, because you might experience some increased symptoms for a time and need intervention. So this second stage of needing maybe some more targeted interventions by psychology or another therapist, maybe psychiatry, which may or may not include medicines. And we'll talk a little more about psychiatry's role, and maybe more focused support from child life. In addition to these things noted below, is that your child maybe is having more heightened symptoms with anxiety or behavior change during hospitalizations that are actually becoming more difficult, but they're doing okay at home. But in the hospital, they're having more distress during that whole time of the hospital stay. Or maybe you notice your child at home is having a hard time, that if they hear you talking about anything related to treatments or when giving medication, they're having distress every time that happens. Or they're having sleep trouble, not just the nights before clinic or the hospital, but most nights. And this is a time to maybe bring it up to the team to say, here's what I'm noticing. What might these things be? And they can ask further questions. But it's not just so localized, and you're seeing it show up a little more distressing. And then there are kids who progress to kind of this more clinical symptom trait, higher spot. And again, you don't have to stay at this whole spot, because you may be able to get treatment and bounce down to any of the spots below, or up and down at different phases during treatment. And so at this spot, I think of especially where you definitely want to make sure you're getting some more intervention is if symptoms are interfering with functioning. And by functioning for kids, I think about how they're doing at home, how they're doing with friends, how they're doing at school, depending on their age and what those interactions are. Are they doing, when they're doing things they like to do and are playing, are they happy? Are they interacting? And are they struggling to engage with medical care? Not just getting anxious and crying when accessing a port, but they're so worried about not feeling like themselves and feeling weak or having pain that when PT or OT and when those physiotherapy and other people come in the room to work with them, they don't want to do it. And you can't get them to engage, and they used to engage. Or maybe even at the start, they're so overwhelmed and struggle. Or it's the child who worries so much that you're having a hard time helping them shut down those worries, and it's becoming kind of consuming of their energy. And at this point, you want to be using more specific mental health support with psychology or therapists and from psychiatry, which may or may not include medication. And so I want to take a moment to talk a little bit more about psychiatry, because I think, at least for us in the United States, sometimes psychiatry carries a lot of stigma specifically about what it means and when your child is going through so much treatment and people not always knowing what it can offer, is that psychiatrists go through medical training, which gives extra ability to have psychological knowledge and be able to think about medication side effects and medical factors influencing psychological symptoms, and put all of those pieces together to sometimes help with a diagnosis. They have therapy skills to contribute along with others in the mental health field, and to consider the role for medications, which is sometimes really challenging for a lot of families, because having a diagnosis of neuroblastoma, going through cancer treatment, means a lot of medicines that your child has probably never had to take before. But that might mean maybe as needed medications, but sometimes might be a recommendation, especially when you have a lot of spikes of anxiety, for potential as needed a daily medication to help keep that in control for some short period of time, maybe days, maybe weeks, maybe months. It doesn't mean forever, but it's worth sometimes hearing about and learning about. And most of us in psychiatry like to look at that with an open mind, to educate families and help you understand what's happening with your child, to help them return to being themselves in the midst of this treatment.
Switching gears to discuss symptoms in parents, if there is one thing, or maybe multiple things, but one of the most important things, if you hear us say anything in this presentation, it is that almost all parents experience at least one post-traumatic stress symptom in the first 2 to 4 weeks after diagnosis. That's a powerful statement. So almost all of you have probably at least experienced one of the following symptoms: recurrent distressing thoughts or dreams, sleep disturbances, being very hypervigilant, having trouble concentrating, feeling really irritable, maybe some avoidance. I mean, the list is far extensive than that. But again, really highlighting that at least the first 2 to 4 weeks, our parents, you're taking on a lot, and especially within the population of our younger kiddos with neuroblastoma, parents, you're carrying a lot of the burden. Most centers have psychosocial support services available to patients and families. So again, if we think back to this model, in the universal group here at the bottom, I mean, this is where we encourage parents and caregivers to really utilize the supports around you. So this may include the chaplain or routine psychology or social work support, psychosocial support from kind of whoever makes up your interdisciplinary team. Family mentors. So a lot of institutions, and even this wonderful organization, has family mentors. Hospitals. I know our institution has a family mentor program, which is wonderful to connect families with another family that's been going through something very similar, if not the same diagnosis. Your family, your friends, your religious communities, your local communities, but really utilizing those supports around you to help you get through the first bit of time, but also just, building a village around you to get through the next steps of your treatment or your child's treatment. Dr. Jacobowski, back to you.
Yes. And so as you kind of notice some increased symptoms, as Dr. Wojtowicz was saying, that you can have these symptoms at a mild level, but sometimes even more significant symptoms as parents. And some of those might be that it's hard to stop yourself from continuing to worry about your child. And cancer treatment causes, by nature of what we ask you to do, on the medical side, to be hypervigilant. If they have a fever, a new symptom, please call the clinic. And sometimes that becomes hard to shut off, even when things are reassured. Or you're constantly fearing the next shoe dropping and the next bad thing to come, because you've had a few bad things happen. and it's hard to feel safe and not on edge. Or potentially things like reliving distressing moments. And as we were preparing this, we were talking about the fact that that might be a distressing medical moment, but it might also be something that was distressing because perhaps you saw your child crying, severely distressed, and you couldn't console them well. And it just sticks with your memory because it was such a hard moment. And it comes back and you relive it, or it flashes back to your memory in certain ways. And we keep that broad because those distressing moments are not defined by some certain threshold of medical seriousness, because there's so many as a parent that can occur, or not feeling like your usual self. And at those points, we really encourage being able to think about seeking your own support. And knowing how verbose I was earlier, I'm going to jump us into our next spot, because why it's so important is obviously we want parents to get the support they need for your own sake. But as we all know, I think in a lot of ways, our kids feed upon us and we upon them, because when you see your child anxious and distressed, it causes you more distress and they absorb from you. And when you carry further, it carries into this place where you're both feeding upon each other, and it's hard for you both to reassure each other. And when you're not feeling grounded, it's hard to do that for your child. And why it's actually so beneficial to get your own help, even though it feels like stepping away from your child in need, because you can actually help your child best. And so our takeaway is to briefly really say anxiety and post-traumatic stress symptoms, they're common and they're treatable, and that supports are in place. And when your child is not your child, or you feel not like yourself, please reach out to those resources. And we will look forward to talking more in the question period.
Thank you.